My name is Eric Mallack. I'm one of the child neurologists at Cornell, and I am the head of the Leukodystrophy Center. And I was invited to talk about the leukodystrophy and what the future holds. Just some disclosures. I am the PI on a gene therapy program for Krabbe disease and one for adrenal myeloneuropathy, and funded by the NIH. I just want to talk really quickly about the work that's going to be presented here. I mostly do clinical and neuroimaging research and then on some of the clinical trials, but most of this work that I'm presenting in this overview is work done by other people. So I'm going to give you sort of, I think, where the slice of the field is right now. So just to give some definitions, the leukodystrophies, they're heritable disorders that affect the white matter of the central nervous system, and they can have peripheral nervous system involvement. They're traditionally understood to have glial cell or myelin sheath abnormalities. And where we know about the neuropathology, it's really oligodendrocytes, astrocytes, anything that's non-neuronal microglia for that matter. So there are three major leukodystrophies, ALD, adrenal leukodystrophy, and you're seeing here cerebral ALD with the classic parietal occipital white matter disease here in the left column, and this garland of contrast enhancement indicating there's inflammatory demyelination. There's metachromatic leukodystrophy caused by gene mutations in the ARSA gene. And here you see these periatrial white matter changes that are degenerative. And if you go a little bit higher, has this classic tigroid appearance in the white matter. This is pathognomonic on imaging for metachromatic leukodystrophy. And then there's globoid cell leukodystrophy or Krabbe disease affecting newborns as well. You can see these periatrial, again, white matter changes, and down here on the T2, white matter abnormalities in the cerebellar white matter and periventricular white matter. So these are the three major leukodystrophies we're going to talk about. And what I'm going to do is give you an understanding of the untreated natural history, what the transplant outcomes look like, so what we've been trying to do to treat these disorders over the past 20 years, and then novel therapies that are in trial right now and coming down the line, notably gene therapy. So I'm going to start with adrenal leukodystrophy. So this is natural history work by the group out of Minnesota, who has some of the largest institutional experience with treating cerebral ALD. So what we see here on the x-axis at the bottom, months post childhood cerebral ALD diagnosis, patient ID on the y-axis. And if I can just draw your eye to the X's here, this is to illustrate the point that this disorder is progressive, and the patients untreated will succumb to disease somewhere between 3 to 5 years post their cerebral ALD diagnosis. Looking at overall survival and major functional disability-free survival, if we just look at the top survival curve here, excuse me. The dark line here is overall survival untreated. It's about 50% at 5 years, and most patients develop major functional disabilities. If you look at the bottom survivor curve here, this GDE positive cohort, so these are the untreated patients who undergo inflammatory demyelination, which is the vast majority and happens most often in childhood. Overall survival is worse, and of course, patients become very sick very quickly. So what we've learned in terms of doing hematopoietic stem cell transplant, if you look at the patients who were treated with advanced disease, and that's defined as patients with really more than one major functional disability or neurologic symptom. If you treat a symptomatic patient with childhood cerebral ALD with stem cell transplant, this dark line on the left here, patients will survive. Unfortunately, they will still undergo continued neurodegeneration because you're essentially treating a patient trying to turn off the inflammation in the brain by introducing donor cells to quiet the inflammation in the brain. But those patients who become symptomatic, their disease will continue to progress until it eventually does halt. But they will continue to garner symptoms over that time period. What we've learned, and if you look over here to your right, is that if you treat patients with quote unquote early disease, so these are patients with evidence of inflammation in the brain, but are asymptomatic. In cerebral ALD, especially childhood cerebral ALD, there is this window of opportunity. The disease will show up on the MRI before it becomes clinically apparent, so before patients develop symptoms. And if you can treat patients in that window of opportunity before they become symptomatic, as you can see, not only do they survive, but the vast majority of patients have their disease halt before they develop neurological symptoms. And that is the goal right now for hematopoietic stem cell transplant, is to treat the patients in that pre-symptomatic window of opportunity. We in the United States have newborn screening in most states for ALD, and those boys are identified at birth. They are referred into an MRI surveillance program. We've done some work that has demonstrated that the earliest we've detected really cerebral ALD is about 2 years old, but 90% of cases present between the ages of 3 and 12. So usually between the ages of 3 and 12, boys undergo MRI surveillance imaging to try to capture early signs of disease, and we can rapidly then take them to transplant. So what is new? So this is stem cell transplant, and early stem cell transplant is the goal and is the standard of care. So this is gene therapy for childhood cerebral ALD, and so this is the work done by the group at Mass General. It's multi-site. This is published in the New England Journal, the first cohort in 2017, with my mentor, Dr. Eichler. And this is a transplant-related gene therapy. So the patients still undergo myeloablative conditioning, so they get chemotherapy. But beforehand, their cells get pheresed out, and then they are sent. The CD34 cells are selected out. They're transduced with the corrected gene. And then once the patients have space in their bone marrow, the cells are reintroduced back into the same patient. So this is an autologous transplant, whereas the standard of care is an allo. Now the patient has their own cells that have been corrected to express the corrected protein, and then this is sort of the follow-up. So this is the data that was published in 2017 from the New England Journal. Panel A on the top demonstrates neurologic function. So that's your neurologic function scale or score. The higher the score, the more symptoms you have. You want a score of 0. So you can see, unfortunately, one patient had rapidly progressive disease, but the vast majority of patients in the trial remained asymptomatic post their gene therapy. The low score here in panel B is the MRI score. So the higher the MRI score, the more affected white matter you have. And what you can see is generally over the course of time, from the time of gene therapy infusion, MRIs will progress a little bit and then overall stabilize, which is what we'd expect to see. So this is the update that has been that is in the long-term follow-up trial and the expanded trial. So now there's 32 boys have been treated, 30 or 94% have stable, again, neurologic function scores. So clinically they stabilize. Unfortunately, this is the one patient that succumbed to disease, indicating that gene therapy is a suitable option for patients who don't have a matched donor for hematopoietic stem cell transplant. Okay, so that's cerebral ALD, what was once a inflammatory demyelinating disorder that was ultimately fatal. We are getting much better at treating it with stem cell transplant, and gene therapy looks promising as a promising alternative to also treat these patients. So I'm going to move on to Krabbe disease, or globoid cell leukodystrophy. So again, we're going to go back to natural history. What does untreated Krabbe disease look like? So Krabbe disease is a leukodystrophy. The gene mutation is in a gene called GAL-C. It codes for something called galactocerebrosidase, an enzyme required for appropriate white matter development. patients with Krabbe disease, if they have neurologic onset between 0 and 5 months old, as you can see, half the patients will expire by about 2 years old. If you have patients who have disease onset 6 months to 3 years, again, survival probability is still poor. They'll live longer. They have a little bit more of an attenuated phenotype. However, they will also succumb to disease. So hematopoietic stem cell transplant has been trialed in these patients. And this is data from Pittsburgh and from Maria Escolar's group. She's one of the world leaders in this. And the survival curves are such that if you look at patients who are in blue, these are untreated asymptomatic patients up here. Untreated patients are in the green, asymptomatic treated patients. And then here are the patients who are treated. If they had symptoms before a year old and symptoms after a year old, you can tell that they do survive. The patients with symptom onset less than 12 years old are really what we now call infantile Krabbe disease. If you treat those kids with transplant, you see to some degree you're approximating the natural history of disease. So transplant in Krabbe disease is harder. The kids are, especially in the infantile Krabbe disease group, they're sick when they're born. And so we think they're sick in utero. And then secondarily, Krabbe disease is one of those disorders that has an associated peripheral neuropathy with it. So the patients that do survive, while it may stabilize the central nervous system disease, patients still get neuropathy and gross motor deterioration. So moving on to the future of therapy. So this is the preclinical work for intrathecal gene therapy for Krabbe disease. This is done by Alison Bradbury. And I don't want to show something that's too complicated, but what we'll point out here is, number one, this was tested preclinically in a dog model, for Krabbe disease, and it was done via intracisternal injection. And let me just orient you to the 2-week high-dose intracisternal gene therapy given in pre-symptomatic patients. And you can look at the survival curves down here in the bottom right-hand corner. The 2-week high-dose patients survived. Patients treated at 6 weeks old, which in the dog is symptomatic, so they have a survival advantage as well. But again, the goal is to treat patients as early as possible. There is newborn screening for Krabbe disease in my home state of New York, and those patients with high-risk infantile Krabbe disease are referred immediately for stem cell transplant. But this is the goal. What we see in the preclinical models in the canine brain, if you look at in this top left corner, a normal brain MRI, you see this nice dark patterning in here. This is normal white matter on a T2. If you look at an untreated dog with globoid cell leukodystrophy or Krabbe disease, the white matter in here is degenerative. It approximates the white matter changes you see in water. And to go through the sham and controls, if you look at 16 weeks of the high in panel D of the high dose AAV gene therapy delivered intracisternally, you start to see this redevelopment of normal white matter, this dark patterning, and at 52 weeks down here in panel H, this brain MRI looks pretty normal. So we think, based on the preclinical data, that the gene therapy for Krabbe disease addresses the central nervous system, just like doing a hematopoietic stem cell transplant. But what it also addresses, what stem cell transplant does not address effectively, is the neuropathy. So the dark squares here are normal measures, looking at 8, 16, 24, and 52 weeks of age, looking at both sensory and motor nerve conduction velocities. And again, the patients treated at 2 weeks pre-symptomatically with high-dose gene therapy approximate normal nerve conduction levels, which is really one of the big limiters for doing transplant in Krabbe disease. So thinking about routes of delivery, this is work done by Hinderer et al., showing that, well, we can give AAV a lot of different ways, IV being the squares, through a lumbar tap being the circles, and then through the cisterna magna being the triangles. And if you looked at vector genome per diploid genome of the host, on across the brain and the spinal cord, you can see sort of the triangles float up higher, indicating that intracisterna magna delivery of AAV has more widespread distribution of vector, and therefore that vector carry, which would theoretically carry the corrected GAL-C gene. So this is updated work from 2018, just looking at immunofluorescence and the expression of the vector. This is intracerebroventricular in the cortex, and then the readouts in the cortex, cervical spine, thoracic, and lumbar, versus intracisterna magna. And you can see you get more immunofluorescence, indicating that there's higher biodistribution of the vector. And the hope for this is to now take this into clinical trial. So there is a phase 1/2 multicenter study for the drug products called PBKR03. I put in my disclosures. I'm the principal investigator for that trial at Weill Cornell. We're the only US site that's open, and we are recruiting. So in the event one of the patients out from the countries where you're from unfortunately gets diagnosed early with Krabbe disease, please give me a call. We may have a gene therapy research option for them, which we are hopeful will help address the disease burden in Krabbe disease. And so in the last kind of 5-6 minutes I have, let me move on to metachromatic leukodystrophy. So this is, again, we're going to do untreated natural history. And very similarly, if you look at the MRI total score of patients diagnosed with MLD, the higher the score, the more disease you have on your MRI. You can see it rises pretty rapidly. Patients become pretty sick within 3 to 4 years old. Their GMFM score, most patients with null alleles never develop. You want a higher score in terms of development. And so I want you to remember the clinical score here on the right, patients not really developing motor-wise and cognitively, and the MRI score getting really high because the burden of disease is high on the scan. In terms of stem cell transplant, there is a survivorship advantage in patients who undergo stem cell transplant, of course, with a lot of caveats. But unfortunately, like Krabbe disease, these patients also have peripheral neuropathy, and stem cell transplant does not effectively address the peripheral neuropathy. So even if patients do survive and their central nervous system disease is addressed, they still have secondary motor degeneration due to the neuropathy. So again, so remember the MRI score rising and lack of development, motor development. So this is the gene therapy that was pioneered in Italy. And here the MRI score, you can see the gray is the untreated cohort, natural history cohort, and here is the patients treated with late infantile MLD and some early juvenile MLD. Their MRIs stabilize and do not get worse, and patients approximated normal motor development. Here again, the gray down here is the untreated cohort. So in about 26 minutes, we reviewed the 30-year up-to-date history of the 3 major leukodystrophies, their untreated natural history, their standard of care, and their novel therapies. So I'm going to end here. We may have time for 1 or 2 questions, but I think we're doing questions at the end.